Hello and welcome to RIVE, Reflections in Veterinary Education. We have another new episode for you all, and Eric is going to be running this one. So I'm going to turn it over to you, Eric, from here.
Yeah, thanks. So today we have a guest on, and to be clear, Joe was on our short list of guests from the beginning, and I chose her, frankly, because it's low-hanging fruit for me, because she and I know each other, and I think that she would respond to my email, which is always kind of a check in the plus column. So, but Joe's also, obviously an expert educator. She's been involved with a lot of curriculum stuff at UGA, which we'll get into. So that was my my motivation and thought process. So Joe, tell us a little bit about your professional progression, kind of how you went through, undergrad, vet school, training, et cetera.
For sure. So I am from the UK, and I went to Cambridge, which is a 6-year degree, as opposed to a 5-year degree from the other vet schools. But before I started at Cambridge, I took a gap year and went to Australia. And I think that's when I got the travel bug. So Cambridge, 3rd year, did immunology, graduated. I don't know at what point I said I was going to stay in academia, but apparently I announced it to my classmates. I was going to be an equine orthopedic surgeon.
Ooh.
But didn't come from quite the right background to convince clients. I think I just wanted to be able to do one thing well. So now I'm a small animal internist. That's all trades. Yeah. So having said I was going to stay in academia, I did go into practice because I felt like I needed to do that if I was going to teach students. And then I went back to do my PhD in immunology. And after that, there weren't a lot of internship programs established in the UK, but I was fortunate enough to fall into a private practice internship. And a lot of those people were specialty boarded. None of them had actually done their residencies in America, but I was like, why not? And in my 5th year at Cambridge, I had done some externships at Guelph, equine surgery, because again, I was going to be an equine orthopedic surgeon, and then actually emergency and soft tissue surgery, because I wanted to round out my education. And so that was when I saw the American system, and I really enjoyed it. And I retrospectively, the Cambridge crew are fabulous, but at least the preclinical year, it's a very academically rigorous curriculum. Mm-hmm. And I don't know that makes for the warm and fuzziest of teachers. Mm-hmm. So by comparison, America had a great caseload, and it seemed, and I think with some reflection, the students obviously paid tuition in America. Yes. We did not in the UK. Mm-hmm. So I came over and there were things like handouts, and actual lectures put together. And so the teaching seemed very personable. The students seemed very eloquent. And I was like, I like this. And so at the end of my private practice, partway through, I decided I was going to try for an American residency. So I got on a Greyhound bus on the Thanksgiving week because I didn't know any better. Traveled around a few places. And matched at Purdue for an internship, and then at Tennessee for my residency. And I think at that point, by the time I graduated, I decided I was going to be a small animal internist. So, so that was kind of that. And then at the end of my residency was around 2008, which is when the economy was tanking. There were some issues with my family at home. I wasn't sure if I was going to be able to stay in America or go home. So I did a clinical instructorship at the end of the residency to try and figure things out for a year. And I worked at Nottingham, which was a new vet school at that time, and had a lot of ex-London people because they wanted to develop a more progressive curriculum. And so, you were given the learning objectives that you had to cover. And so I taught endocrinology for a month, write a lecture, give it, do a lab, write it, give it, it was fabulous. And at the end of my clinical instructorship, I got to go back, teach the 1st year again, and then write the 2nd year. So that was a really nice grounding and exposure to education before I started my faculty position at Georgia, which I did in 2009, and I have been here since.
I love these. Like, it's amazing. You think you kind of know people's stories. I think you just sort of fill in what you think or you assume. And Equine orthopedic surgery is not in like, yeah, maybe in a million years because I would have run out of options, but
Yeah.
peg that. That's awesome. That's really cool. So I'm curious. I know this is maybe a little off topic, Eric, but I can't help it. Like what led to the switch to small animal internal medicine?
I think there generally is a bit of class system in the UK, and I am working class and I don't speak with the right accent. I also had never owned horses. And so I'm like, I think it's the Paston. I think it's the Paston, or they've just called it something else. And the rest of the family are actually police officers, and I think they're problem solvers. And we talk about, evidence trail. And so I did everything else except small animal internal medicine as a specialty, I think because I felt very comfortable in it. And for me, I have a criticalist friend who calls it eternal medicine, and that's not necessarily the biggest attraction for me, but it is trying to diagnose problems. The humanism aspect of long-term relationships also appeals. I think I figured that out. So at some point, I think I got possibly scared of equine clients and also equine practices, and settled into my comfort zone, which was internal medicine. My first choice job would actually be a surgical assistant, but that doesn't pay so well apparently for a DVM. So
yeah.
I'm really interested in what you said about, you felt like you needed to go into practice if you were going to go into academia. So with the hindsight that you have now, how do you feel about that? And do you think we should all adhere to that?
I possibly 25 years since I graduated. And so I am very cognizant. People talk about the ivory tower, and I've been in specialty practice for 20 years. And so I found it very helpful because the transition to practice, I didn't have a great first job, and it taught me a lot about what to look for in a practice, taught me a lot about how important communication is. And the challenge I have now is I've never actually practiced in the US. And so I do feel like I'm teaching students and I don't actually know the system they go into. In the UK, veterinary nurses are not utilised very well. I realise they may not be utilised very well in this country, but it certainly seems like, have veterinarians running multiple rooms and that kind of thing. That never happens at home. And so I'm kind of curious because I talk to the students about communication skills and history taking, and talking about finances. And yet it seems some aspects of general practice in this country, that's not what the veterinarian does, So I wish I was a little bit more knowledgeable about that. And I think the problem is the further you're in your specialty, the further away it is from your, like, what was it like being a day one graduate again?
Yeah.
And that's the bit I struggle with. And I don't know whether spending time in general practice would help, because I think it's slightly compounded by distance, and I realize for me, the irony is the intern residency program almost favors students not doing that. You go out, you've got to figure out how you're going to get your letters of recommendation from people with letters after their name. And, I talk to people about doing sabbaticals and being a staff veterinarian at a specialty clinic. Whereas to be clear, I started my PhD 5 years after I graduated. And so I started my internship 2003. Anyway, it was several years after I graduated. And I felt at that stage, I was probably good at talking with clients and managing my time. And I knew what I wanted. I've always kind of been a bit goal driven. And so I don't think it hurt me, but I realized the pathway that we have doesn't necessarily support that for interns and residents, let alone for faculty.
Interesting.
Yeah, I want to jump in there actually really quickly and see, because I know, so I'm the only person here who is not board certified. I don't have a specialty clinically. And so I'm curious, Eric and Bobby, I don't know if either of you have actually been in a general practice or been out in a private practice outside of academia. So I'm curious about that and whether what Joe said resonated with you or not, because I obviously have a very different perspective because I was in private practice for 13 years, general practice.
So, so as a veterinarian, no, I have not worked as a veterinarian in private practice, but I did work all like throughout vet school. I worked at emergency practices and things like that. So and before. So is that the same? No, clearly not. I do think, I don't necessarily know why. I do think I have a reasonable perspective on that. In fact, when I was an intern, I had a student asked me one time, like, how long were you in practice before you did the internship? And I was like, how old do you think I am? And they're like, oh, no, it's not that. Because I think, even just working, as an assistant and those things, it was giving me like that perspective. I don't know. I also all throughout vet school was not planning on academia. I was always planning on going into general practice. So like externships and things I did, that was where my mindset was. And when I decided to do an internship, it was to make me better. Like the idea was to get me better at, for going out into general practice. Like that was always the goal. And so I don't know if that has anything to do with it, but I do think I try to recognize the difference between what is, specialist level, information versus what is a day one graduate really need to do. Some of that I think is because ER is kind of one of those weird, bridging the gap between specialist medicine and first opinion medicine. So that may be part of it as well, that there's just a lot of very practical things, and whether you like it or not, you got to be prepared for spectrum of care. And so that might be part of what's, I think, kept me a little bit more grounded, but I did not ever practice as a veterinarian in general practice. So I've been in academia since. And yeah, I mean, I feel like that's been okay, but I think what, Joe, what you were saying as far as how well are we preparing students for, what is out there? I think there's also so much variety out there right now that, the jobs look so different. And what I encourage students is to say, think about what you think fits for you. And then it probably exists. And if it doesn't, create it, because, that's kind of, I think our profession is very flexible in that regard. I do think what you said about the timing of when to do an internship or residency is an interesting one. I've always thought that doing an internship immediately after vet school seems like the easiest time to do it, not just partly because of getting recommendations and things like that, but also like financially. People that have gone out and like saw the other side and have to come back, it's hard. And then there's the academic side of things, like being used to being a student and reading up all the time and doing that versus not. Those transitions are challenging for people. And so I think there's some of that is part of that natural inclination to want to be like, student, intern, resident. But we all know people that didn't take that path and have been successful. So I also try to remind people, like, there is no one path for anyone, and forge your own. And if you need to, like, pave a new path, that's not a problem either. So I don't know. That's my long-winded response there.
Eric, I'm curious about you.
Yeah, my internship was in private practice, and one of our rotations was at a general practice. So, we were seeing appointments and doing surgeries and everything like that with relatively minimal supervision at that place. And then in my residency and early in faculty days, I did a lot of shifts at an ER in Atlanta, Calvary Emergency Veterinary Clinic. So when I was an early faculty member, most of my case examples were from my ER shifts, because I'm like, this is what you're going to see because I just saw it. Like, you need to be able to sedate a Labrador that cut his foot on some lawn edging, like, and I think that that's very much informed my whole approach to anesthesia. Is like, you do not need to know how to anesthetize a French bulldog with pulmonic stenosis and ASD, right? Never need to know that. You need to sedate a cat who needs to get deobstructed.
Yeah.
So that's kind of why I asked Joe, is like, I feel like my experience in the real world definitely informs how I teach the students.
Yeah. What I'm saying is, you don't need to go into private practice. You need to do emergency work.
Not that you're biased.
No, that's not biased. That's very objective.
I think the UK system as well, at least when I went through, there weren't a lot of internship programs established. And so it was very typical. So most people in the UK, you know, they start at 18, 19, they're usually finishing 23, 24. And actually residents go out, most residents would go out into practice for 3 to 5 years before they would come back. So that was kind of the culture that I came from. I definitely agree with money. The fortunate thing is that I had training through a PhD. I was just talking to somebody today about how you learn to live very simply. And I was fortunate enough that I came from a working class background. So I never had far to fall, perhaps. And so, but yes, and you learn to live very simply.
So
Yeah.
Joe, thinking about, you know, your decision to enter academia, you said you made that very early on in vet school. What like in your life leading up to that helped make that direction for you? You kind of mentioned a little bit the class system in the UK, which I honestly don't understand at all. And I wonder, did you have like early formative experiences? Like were your parents educators, like those kinds of things?
Not at all. My dad was a policeman. My mum was a nurse. And I honestly, I don't know. I mean, Cambridge is an amazing example. I think I like to try for things that I can't always reach, like a challenge. You know, I applied to Cambridge for what we call a deferred entry, a year off. And they were like, I got rejected outright from 3 schools because like, we don't do that. I was like, okay, well, I think it can only benefit me and I'm doing it. So I do like to set myself a challenge. And having done the Strengths Finder, apparently I like to read. I didn't think that was quite novel, but I like to read and I like evidence-based practice. So I don't know if it was the combination of my experience in America, having the fortune to do the clinical instructorship and work with Nottingham. And to be honest, I mean, one of my most formative mentors is India Lane, who was at Tennessee when I was there and is still there. And I think, you know, she started to instill into me that education is a science, you know, pedagogy, and you can learn to get better at it. And I think that's really what started the interest ticking.
I love that. India Lane is, I think, someone that many of us have in common, because I actually had conversations with her during my senior year of that school about potentially doing a 1-year education internship. And so she's definitely touched a lot of lives. But I'm curious for the education side of things. So I've had conversations with quite a few people who have gone into education, especially those who are specialty trained, and worked on a paper that I published with Julie Hunt and Sarah Bailey. And one of the things that we found in that paper was that those folks who sort of selected this education track per se, as they were going through, whether that was sort of conscious or unconscious, is they had a real difficult time sort of almost coming, they all had this moment in their careers where they came to a crossroads where it was like, I either have to do education or I have to do my clinical specialty. And this is a really difficult crossroads for them. So I'm curious if you've gotten to that crossroads, and if you have, what that was like for you. And if you haven't, do you see that coming, and do you think that's going to be a challenge?
I think I've got that crossroads, and I'm definitely on the education track. So for me, and I think it's because I like to strive for stuff that's really hard. And so the whole imposter syndrome certainly kicks in, right? And I was fortunate enough because I'm doing the RVC master's program. Sorry, it's not the LMU one, but I started on the certificate and the diploma. COVID happened, slight gap. And so I felt that I was getting more specialized in that. And actually, as an internist, my interests are immunology, hematology, and endocrinology. When I came to Georgia, somebody had firmly grabbed endocrinology, which is what I was teaching at Nottingham. And I never really got to develop a subspecialty in internal medicine. And I felt like my subspecialty was education. And so I spend most of my time reading educational papers, and I actually feel I don't know that I'm a good educator, but I'm probably a better educator than I am an internist at the moment. And so the flip side to that is the other half of my life is being the medicine service chief and the residency program director. And so I haven't actually been able to completely give that up, but there's also a strong educational mentorship streak in that role as well. So a jack of all trades is a genuine label that I apply to myself as an internist without a definitive subspecialty.
I just want to say, I love the fact that you said you like to set yourself up for things that are challenging and difficult, because so many people I talk to don't think education is challenging and difficult. And my counter argument is to educate well is like the second hardest job in the world.
Right.
Right. But so many people just don't see it that way. So I love that you said that.
That quote about those who can do, those who can't teach makes me wince.
Yes.
Yeah.
So thinking about internal medicine in particular, how do you feel teaching internal medicine is different than teaching other disciplines?
Well, the irony is I don't actually do a lot of didactic teaching of internal medicine. My focus is kind of got seconded onto professional skills. For me, the little bit of teaching I do, I've still got some immunology and hematology. It's the focus for me is clinical reasoning. And that is, I think, trying to teach students an approach. And that's the thing I focus on in internal medicine. We spend a lot of time talking about getting to a diagnosis, right? Because as internists, we're delirious if we can actually achieve that. And then we kind of take it for granted that people are going to be able to manage to figure out how to treat things. And clearly specialty medicine, sometimes we've got an odd combination of diseases that we have to treat. So for me, it's really trying to teach the approach to clinical reasoning, which might actually now be a course in our new curriculum. So that's really interesting. And coming to it from a systems viewpoint and trying to teach people to be systematic in their approach, I think. Yes, and I think the thing that I have never really been able to overcome is you just wish you could inject the students with 3 to 5 years of case experience. Because to me, I talk to them about, I'm like, you're just jumping off the springboard because I'm asking you to think aloud, tell me what you're thinking, and you don't necessarily yet have enough case experience to know the wood from the trees, and also you don't have the case experience to inform your clinical rationale and those feedback loops.
That's interesting.
That's the bit that's really hard.
So you've mentioned now a couple of times that you come from a family of police officers. And I want to circle back to this because this is something I've said a number of times, and I want to get your thoughts on it. But sometimes when I'm talking to students and I'm trying to verbalize like my process when it comes to, coming up with a diagnosis, is I liken it to, I am a detective trying to solve the case, the crime, right? And so sometimes I have this evidence along the way and I'm trying to build a case, and sometimes we find the smoking gun, right? Like there's the answer, the test is positive, but a lot of times we're just collecting evidence and we're trying to make a case. I'm trying to present to, a jury, whatever. I don't, I kind of go a little wonky with the analogy sometimes, but I'm trying to collect evidence. The other thing I think about is, sometimes I am reading like a mystery novel and I've read the ending, right? Like I know the results of what happened, and I'm trying to create a story that makes logical sense. So like those are sort of two, kind of analogies that I've used, with students when I'm trying to say like, here, you're like in the middle of the book, right? You have this information, like the animal comes in with a history and a case presentation. And sometimes we have the prior information, but a lot of times a lot is missing. And so like the first, 3 chapters of the book have been ripped out, and you have to fill this in a way that makes sense. Right. And then also at the end, like trying to come up with an ending or a story that makes sense, that is logical, because nobody's going to want to read your book if it jumps all over the place, doesn't make sense, or you open the line, it's like, and it was all a dream. Like it's gotta be good. It's gotta make sense. So coming from a family of police officers, I'm wondering, if that same kind of approach has ever occurred to you, or what your thoughts are on that.
I love the book analogy, but no, I mean, absolutely. I just say that we're my sister's a detective. And so I'm like, we're problem solvers and we're trying to gather evidence. So, and my sister is a twin. So we both talk acronyms at each other a lot, and we both talk about the challenges of the system, about administration at work. But no, we're absolutely detectives.
Yeah.
Surgeons get to fix things. Medicine gets to figure out problems. and potentially sometimes, and potentially manage them. We don't fix them.
Not often.
But yeah.
So I find this ironic in light of the conversation that we had before we came into this actual session, because we were talking about administration and how administrators are generally problem solvers all the time. And you're like, I don't know if that's really for me. It sounds to me like the logical next step for you, because you've said you're a problem solver like many times throughout this.
I mean, well, yes, although I also like things to be, this is why I'm not a criticalist, I like things to be semi-organized and predictable, right? But no, I think, I mean, it's a broad term, but I think of veterinarians, if you had to tell me what they were, it's problem solvers.
Yeah.
That wears many hats. But the flip side to our conversation is we were talking about the rewards of working with patients and also working with students, whether that's students, interns, residents, technician students, whatever, you know, even general practitioners when we're giving CE, and you don't necessarily get that hit in academia, in administration. So that's truthfully, that's the bit that I'm like, well, when do I mean, I certainly applied for a few jobs, made it to the last two, not the last one, that's okay, bit of a breathing space. But that's the thing I had to ask myself is, are you ready to leave that reward behind?
Yeah. Yeah. And I think that's part of that. Also part of sort of figuring out, do I go the education track? Do I go the administration track? Like, how do you navigate that? And I just have to put this out there because it's in my head. When I was in practice, I loved surgery because I'm that person that like, I want to go in there. I want to go in there. I want to know I can either fix it or I can't fix it. Right. And so I've had arguments over the years with several of the practice managers that I've worked for. And I'm like, I'm not an internist, I'm a surgeon. Don't send me the internal medicine cases. Don't send me those complicated things. I just want to cut it and cure it. And one of them just looked at me, she said, you know, you're wrong, right? And I was like, what? She's like, you are an internist. You like to solve problems. You like to figure out the mysteries. You are an internist. And I was like, but I like answers. So I'm starting to come around to her thinking because of this conversation. Is like, oh, she was right.
Thing though, Joe, because you talk about, I hadn't really thought of it this way because I've had the same, like, you know, what does my career look like over time? And I've, you know, thought about, you know, why is it that I struggle with the thought of like leaving clinics? Like, and it is a struggle. And I hadn't really thought of it in terms of like the rewards that you get. And I think that's actually really insightful to think about what are those rewards, which kind of goes along to what you were saying, Catherine. I think that's one of the things that's so rewarding about surgery, right? But I 100% agree, Joe. Like everybody, you're problem solvers. Like nobody says like, that surgeon is really good because they can name all the origin and insertion points of, you know, they're like, oh, but when in surgery, if something goes wrong, they can troubleshoot, they can solve that problem. That's what makes us good at things, right? But what makes us like things is maybe about the rewards that we get. Yeah, I hadn't thought of it in those terms. And now I have to do some self-reflection and think about like, what are the things that I'm actually like, what are those rewards that I'm worried about losing? And are there other ways to get those kind of rewards in different ways? So really interesting way of thinking about it.
So thinking about rewards, what are some successes that you would say that you've had educationally, Joe?
Yeah, I had to really think about this question because I know that this is not meant to sound as a false modesty, but I actually don't think I'm that good of a teacher. Like I don't do a lot of innovative teaching techniques. I certainly do some active, you know, teaching, and I try and be approachable. And the students certainly know my life story by the end of our professional skills class. But in terms of successes, I think perhaps getting well-being into the curriculum early on, being able to take 5 courses and weld them into one as professional skills. Now that was definitely initiated by Karen Cornell and Katie Creevy, but they made their little baby and then they gave it to me as they did to Texas. And I was like, okay. Most recently, probably switching us from a grade to a pass-fail marginal system is probably a major victory because I kind of bludgeoned the other faculty to death with the evidence.
Well done.
Yeah. So
yeah, good job. All of us are fully supportive.
That's
Awesome.
probably the most tangible achievement that I've received, I think. And then, yes.
You know what I want to say though, that you can be a fantastic educator and not necessarily be innovative, right? So
Yeah.
I do think that you are innovative. I think you're more innovative than you give yourself credit for. But I also think there's a misconception out there that you have to be disrupting the system or doing something brand new. The fact of the matter is there's very little less left to innovate in education when it comes to teaching and theory and those kinds of things. But you care about your students. You are committed to giving them a high quality education. You're willing to do the reading. You're willing to do the hard work to meet the challenge of being a good teacher. And I think you undersell and underestimate yourself when you say that, because there are so many teachers out there who don't do those things. So I just want to put that out there and say, I think I've never seen you teach, but I know your reputation. I know the things that your colleagues and your students say about you. And so I just want to
That's very kind, because I have too many interests in teaching, I think, to be effective sometimes, a little bit like being an internist. So, which is great, because I read some things about a lot of things, you know, and then you start to see how things connect as well. And especially with professional skills, because it's such a broad curriculum. I think it's interesting, you know, how does well-being connect with spectrum of care to professional identity formation, to transition to practice? I mean, you just read about that all day, and I love it.
I think what Catherine's saying, though, really resonates too, because I think a lot of the best teachers are never satisfied, right? Just like a lot of the best clinicians, as soon as you're like, all right, I know I'm the best, I don't have anything new to learn, like you're going to get worse. And so teaching is the same way, right? If we're not asking ourselves that, you know, how are we doing? Is this the best thing I could be doing? Even just small tweaks are huge. But it's that caring and wanting to do well and reading about it and saying, okay, how do I incorporate these things? Because it's the ones who are like, oh, anybody can teach, you know, it just, you show up and you say the things and they'll just magically absorb it. Yeah, so I think mostly what it, you know, the mark for me of a good teacher is somebody who's like never like, okay, I'm done, I've learned everything, I'm the best teacher, right? It's that constant striving, like, okay, what can I do better? How can I tweak this a little bit? And obviously that you're doing that. So it isn't, for a long time, it did seem like it was about innovating. Oh, try something different. It's like, or you can just do this really well.
Yeah, I think I'd say doing the basics, but if you think about a veterinarian, doing the basics well is very satisfying for your clients. And so if you pay attention and you do the basics well in pedagogy, your student will probably be happy.
Yep.
Yeah, I mean, you know, that's something that when I'm mentoring faculty on, a lot of times it is the basics. It's listen, look them in the eye, be a little bit vulnerable, use their first name, right? Like learn their name. Those things are so important and they're often missed. So I agree 100%. I mean, my bar may be a little bit lower than Bobby's. It's like maybe somebody who's put enough effort into actually review their slides from 5 years ago and maybe update them is probably better than average. But
no, I was thinking about this the other day, and to me, and this, I don't know, this may be a bit cuckoo, but I think if you're as an internist, right, relationship-centered care is very important. And involving clients in the decision, and also the communication skills that come with that, and being empathetic. And I think that's just what being a good educator is, potentially. It's a partnership, and a lot of the skills that I think will make you a good veterinarian, at least in my field, I think could probably make you a good educator. So that's my latest penny dropping.
Yeah. Or a good detective, or a good, like, funny how these skills translate to so many fields.
So thinking about, you know, always getting better and pushing yourself, like, what are some challenges that you're facing educationally these days?
I'm in battle with the administration to try and let me be the professional skills czar at UGA, because I really think we have a clinical skills director. And in the new competency-based veterinary education framework, I realize clinical skills are very important. It's one domain. Professional skills is possibly up to 7. And I think it would be great to have a longitudinal, so in addition to horizontal, vertical integration and scaffolding, all the words that we use. And professional skills at the moment is going from 1 semester to 4 years.
Nice.
So I think that is, and certainly some of the material we're teaching and we're just trying to bring it into a course, but that's the thing I would really love to achieve. And because I'm passionate about professional skills and well-being and professional identity formation, I think that's quite important to graduate success. The challenge of teaching professional skills for me, to drop some lingo, is the constructively aligned assessments.
Mhm.
Good teaching is not easy, and trying to do assessments that really evaluate professional skills is a thing that's turning my hair slightly white. As our class expanded from 100 to 150 students, I'm like, ethics essays, that's going to be a challenge, you know?
Mm.
And trying to make things like reflection work for students and not just busy work. I mean, most of what we do in veterinary medicine is 10 to 20 years ago in the human medical education. So fortunately, a lot of people have kind of plowed that furrow. So more reading, but those are probably, and just, you know, the general lack of resources. And so it's very gently suggested I could do an OSCE at the end of the first year. And I was like, with what resources? You know,
Yeah.
and also, what are we OSCEing? Like, what's the purpose of that assessment? A bit more clarity. And just the general challenges at the moment is our curriculum renewal. And there's a lot of concern, truthfully, amongst the clinicians. I'm sure it never goes well, right? But there's a perception we're on a split campus, and so the clinicians are at one end and the first and second years are at the other end, and that's a time challenge. And then just trying to get integration, the horizontal and vertical integration, and that may be the planner in me, but I very much want to do backwards course design.
Yeah.
And we started with the first year out of necessity. I'm afraid I was a large cog that jumped and was like, I don't think we're ready. So we actually put the curriculum on hold for a year. And we haven't necessarily made as much progress in the last 12 months. So it feels like we're driving the car and building it at the same time. But truthfully, I suspect most curricula are like that. And I try not to be a perfectionist, but I would like it to hang together.
Yeah, that's hard, right? Because you know, if you get it going and it's not ready, everyone goes, "Yep, see, we told you." So there's a lot of pressure to have it. It doesn't have to be perfect, but it's got to be good enough that, you know, people are saying, "Okay, we see where this is going, and we'll hang in there to make some tweaks." It's tough.
Yeah,
And we do always start with like the first year, like the
Mhm.
freshman class.
Mm.
Whereas if you're doing backward design, you need to do the other way around, right? Like you need to start with the first and then go back. Yeah.
yeah,
And that's, I can speak to this right now. Bobby and I are actually working on doing a curricular review and revision, and we're supposed to be looking at the third and fourth years because the first and second years have already been done, right? And this was one of the charges that the dean gave me when he hired me into my role, which was, hey, we need you to review this curriculum, at least the third and fourth years. And I looked at him and I said, I can't review the third and fourth years without having the leeway to also look at the first and second years, which I'm sure Bobby was thrilled about because she's the primary leader on this effort. But the fact of the matter is, I think everybody does go in with good intentions, just like you said, Joe, like to do, you know, we want to know what our end product looks like. And that's what we're in the process of doing now, right? We're like, this is what we want our end product to look like. Are we actually doing that? And where are we falling short? Where are we doing really well? And then you're supposed to go then, okay, well, what do they need to do in the fourth year to look like this at the end? Well, what do they need to do in the third year to look like the fourth year who's going to look like this in the end, and so on and so forth. And so that's great. I think that you got them to stop and really think about it for maybe a year, because what happened at Virginia Tech is that the first 2 years did get pushed through. And now there's such a disconnect between those first 2 years and those last 2 years for the students and for the faculty, that now here we are again, 7 years later, having to kind of review and see how we can tweak it.
Yeah, and I think there's an additional challenge, perhaps, and this is going to sound ruder than I intend it to be, but you know, our basic scientists were chomping at the bit, right? Because most of them teach in the first year, and then they teach in the first year and they're done.
Yeah.
Whereas the clinicians were getting brought into the first year, they're also teaching the second and third year and the fourth year. And as you roll out a new curriculum, they're also teaching multiple curricula simultaneously.
Yep.
So that was just a little bit of a challenge, I think, conceptually, for us to wrap our heads around. And there's also quite a lot of change in our semesters, and we are used to do electives. We're all just going to put those to the third year. And so I was like, so how are we going to decide what's going to be in the third year? Is it just going to be what's left? Or
That's what happened
Yes,
for
that's exactly what happened at Virginia Tech. And it's working, but it's not sustainable at this point.
Yeah, exactly.
So I think that was really, you had some really good foresight there. And my last comment is you talked about horizontal and vertical curriculum and integration. And one of the things I find is that vertical integration is much easier than horizontal integration because horizontal integration requires you all to talk to each other. And that just doesn't happen.
It's been the hardest thing because we're supposed to have these integrated sessions in our first year, and I keep going around and saying, so what are these cases, right? Because I feel like professional skills is going to be this bolt-on, and it's always going to feel like this barnacle on the side of veterinary medicine unless we actually incorporate it into integrated cases.
Yeah,
it's through all the semesters. I was like, so surely if you can't talk about ethics or animal welfare or finances and or communication in any case, and you're right, that does requires communication and time.
Yeah.
Yeah, when I had the cardio course, I had the person who does our communications come and do a talk about communications, and then I gave them an assignment, like, pair up with a classmate, talk to them as if they're a client about a cardiovascular disease, right? So it's still relevant. And I mean, that seems like low-hanging fruit to me. Like, that seems super simple. We can just do that the whole time. And like, do up, Dr. McMichael, who's took it over from me, has them do an assignment where it's like, do up a diagnostic plan that's like gold, silver, bronze, and like go to the hospital, find out how much it costs, and like, it's easy. Just put that in an assignment.
Yeah.
And I was thinking, spectrum of care is, perhaps the latest buzzword, and everyone's like, oh, we do that. And I was like, you might think that you offer treatment options, but the whole communication, the value, the relationship-centered care, eliciting the client's goals. I'm like, and my goal of having kind of the professional skills czar is that if we've got some frameworks which we're teaching them in the first year, it would be lovely, not that we need to be exclusive, but it would be lovely if other people also leverage them so that they get reinforced. And that's exactly it, Eric, right? You can come up with a gold, silver, bronze scheme of diagnostics and treatments, but how do you get that information from a client? And clearly every discipline is different, and I can't necessarily talk to people about large animal surgery. So that person with that expertise would, anyway. So yeah, I'd love for us to be having more conversations, make it more.
We had a huge problem, in my opinion, at Midwestern where we did communication, like this very elaborate communication setup with them for like 5 semesters. And then they got to the clinics where none of the veterinarians had gone through that training. And the vets just keep doing their thing. And the students are like, oh, like, where's your signposting? And like, the students are conversant in all the terms and the DVMs have no idea. So like, all that work that they had done just completely obliterated.
For sure. I know some people in our administration think that teaching communication skills is actually teaching people how to manipulate others. And I'm like, whoa. If it ends up with better patient and client outcomes, why wouldn't you adopt that as a skill? But it's similar to well-being, right? We perhaps talk the talk, but don't walk the walk in the clinical year. And certainly for our house officers, our interns and residents, it's getting harder.
And I would say that you're very wise in this idea that that potentially the professional skills is going to become a barnacle, because that is certainly something the students don't view professional skills as valuable in our current curriculum. And yay, I get to take that on next year, so that'll be fun. I have some ideas for how I might be able to do that, but you're right too, Eric, right? Like, you just integrated across, all of those professional skills are involved in every case that you deal with. And I will say, circling back to general practice, having 13 years in general practice, like that gold, silver, bronze spectrum of care, I've been doing that since day probably 3 of my general practice, because of the spectrum of people that came in and spectrum of willingness of people, right? It wasn't just finances. Sometimes you had somebody coming in a Mercedes carrying a Gucci bag, but they were not going to spend more than $400 on their pet. And you had to figure out how you were going to manage that and communicate that in a way that didn't make them feel as if they were this horrible human being. So circling back to, I think, the beginning of our conversation, I think for me, that's where that GP practice is so invaluable, because I've practiced that on a regular basis. What was that, Bobby?
I'm going to say, or emergency, because again, and it's-
Well, yeah, and I did a fair bit of emergency when I was in GP as well.
think
But absolutely, you just
from-
never know what's going to walk through the door.
Yeah. Well, and yeah, I think what you were saying, Joe, about, like, where are we going to fit professional skills? It's like literally everywhere, like literally everywhere through this. And those opportunities. So I my emergency critical care course is in the 3rd year of the curriculum. And so I do the same kind of thing that Eric was talking about, where, okay, these are specific things we're going to do. We have a social worker in the hospital. So I bring her in and we have our ethical discussions, and here's some emergency cases. And now this is the scenario, or here's the communication scenario you're dealing with. And because that's when it's easiest to me to talk about it in those circumstances. And then it resonates really well when you talk about it like, yeah, we're going to talk about this case and what we want to do medically, but also this is the budget, or also this is the other limitation, or also you can't get a hold of the client, or all those real life things that, come up all the time. And I'm sure, like I've told Catherine this before, it's super easy for me to come up with these scenarios because I had and so, yeah. And you're like, I'm not spending any energy making these things up because they've happened. And I'm like, oh, here was a good one. Let's share this story. What would you do? Okay, well, at the end, I'll tell you what I did, and we can, dissect what were the mistakes there. But like, and the students are like, oh yeah, they're interested in this. They want to have these discussions. They want to, so it's how we package it. And what you're describing to me of having these integrated sessions where we incorporate this is the perfect time to do that, because then the students see the intrinsic value, like, oh yeah, I am going to have this conversation. And if you bring real stories, they're like, oh, what do I do? What would I do?
Yeah. And it's applying it, right? And the difficulty is that they want things to be very black and white, and they don't necessarily like gray zone, which is the whole of internal medicine. But I just, without wanting to browbeat people with the evidence, the whole vet set to go employability scheme, none of that is biomedical. The non-technical competence for new graduate success, whether it's the older paper, the BME guide, or the newer international paper that Marden Cake's done, none of that is biomedical or actually surgical skills. And so, and when I think about longevity in the profession, that's again why and I clearly everyone is adamant, whether it's ER or professional skills, we all think what we're doing is most important, but that to me is why professional skills is so important, because I think it's intrinsic to the transition to practice. And whether you're in public health or emergency preparedness, not necessarily in general practice, it's those professional skills that will keep you in the job.
Yeah.
I would say two other things. I'm actually working on a paper talking about a mentorship program that's been implemented at one of the large corporate practices. And so I'm doing some of the reading on that transition to practice, which is really interesting. But the other thing I would say is that I think professional skills also encompasses sort of that DEI realm. And it's another one of those things that tends to be sort of segregated and said, here's an extra thing that you need to do. But if you think about that scenario that Bobby just talked about too, right? So you call the client, but the client only speaks Spanish. What are you going to do, right? How are you going to communicate in a way that is satisfactory and gets to a good patient outcome? Again, the spectrum of care in this particular situation, you call a client and they have $50. I've had the person walk into me and say, there's a problem with my dog's toe. We literally had a guy walk in pushing a cart, a dog, when I was working for Banfield, with his old dog in there that had this horrible toe tumor. And we were like, oh, this guy's just not going to have any money. And he didn't. But you know what he said? Well, can you give me an estimate? I get paid next week. I'm going to come back because I want my dog to get his toe taken care of. And he walked out and we were like, we don't think we're going to see him. Week later, he came back, plunked down his entire paycheck so that he could get his dog taken care of. And so it's this idea of not having those predisposed ideas of what clients will and won't do. That's all DEI, that's all inclusion, that's all equity. And those are things that don't need to be separated. Like professional skills don't need to be separated. They all need to be incorporated in everything we do. And that's going to make our profession better. So I think there's strong case.
The analogy I used to give my students is when I'm working on the farm at the weekend and something happens to one of my pets and I scoop it up and I bring it to the ER, don't judge me, because actually my dog was insured for $20,000. So, it's the classic cliche. But yeah, anyway, that's my soapbox about professional skills and why I think it's important, especially nowadays, with longevity in the profession and retention.
Yeah.
Absolutely.
So Catherine mentioned the research project that she's doing. Are you doing any research in education, Joe? Do you have any projects going on, or is there anything like I'd really like to do this?
Yeah, well, I had 2 projects that were funded and then COVID hit. So one of them was on well-being and the other one was actually on peer review and the benefits. I have the students review each other's ethics assignments. I think that's a good discipline that would benefit from, you know, multi-source input. And I'm doing my first foray into qualitative research for professional identity formation, which is a little bit like grasping smoke. So I think it's a discipline that very much lends itself to qualitative research. Apologies, Catherine.
Oh, no, don't apologize at all.
You know, it is a complete mindset shift. But I guess if I was looking at analogy, the biomedical skills are very cut and dry and kind of quantitative. And I'm going to say professional skills are the warm and fuzzy stuff that really, you know, add to practice. And so, like when we get feedback, I don't care what the number is, I want the comments. And so it's that idea about quality. And I just wish I'd come to this about 10 years ago. Because I'm like, I can spend the rest of my life researching this. And I have failed as an academician to be successful in converting my efforts into publications. If I had my time again, I would be like, consider it like any other discipline, collaborate, get out of your niche or potentially out of your college if you're the only person necessarily who is firing that furrow again. But you know, if I was going to do an immunology project, I would certainly look and see who else is doing that work. And so I would really encourage educators to collaborate, because we realize we're all kind of muddling along together. And you know, and just for a practical viewpoint, you get your papers published, right? If you've got collaborators, you're sharing the workload, and publications are currency. I'm an associate professor. I will probably retire an associate professor because I do a lot of service and I do a lot of education. And I know, Eric, you are very successful at converting things into publications, and I never actually really learned that trick. But my current project is looking at professional identity formation. And I decided to use appreciative inquiry because I'm fed up of problem solving, and I wanted to sit in a zone of kind of gratitude and things that are working well.
Well, so on that, if you need any help with the qualitative stuff, let me know. The other thing is, I know I have met Elizabeth Armitage Chan, who's done a lot of work in professional identity formation.
Yes.
And the third part of that is that I actually am sitting on the dissertation committee of a veterinarian who's getting her PhD in education. And she is also working on professional identity formation. So if you have interest in meeting her, I'm happy to make those connections because she's
I'd love to. I think Liz might actually end up being my examiner. She's not currently my supervisor, but certainly she seems to have published the most on it, at least in veterinary medicine. And so there's a lot of her papers cited in my master's thesis introduction. But I'm also very interested in your transition to practice, because I think, and Eric and I were in a meeting earlier today, I wish, and it's probably because I struggled. My first year in practice was really hard, and I think I probably nearly left the profession, which is horrendous. You just spend 40 life up to that point, getting to that point. But I wish that the CVMs could reach forwards to help mentor those new graduates. And I wish that practitioners had the time and the ability to reach back and do longitudinal mentorships, a little bit like the longitudinal preceptorships. And so in the UK now, you can't hire a new graduate unless you've actually undergone, I think it's 12 to 15 hours of mentorship training. It's a small country with one overseeing Royal College of Vet Surgeons, and they've implemented that measure. And so that, I think, and it's probably a continuation of the professional skills, right? Because there's lots of CE out there for helping your biomedical skills, but the things that people struggle with is one of those things, and it's reflection, and it's conversations, and it's feedback, and it's mentorship. Yeah.
So I'm actually, to speak to your point about collaboration, this is in collaboration with somebody who is creating that mentorship program for VCA, who approached me at VEC last year. And so we're doing that sort of extra institutionally, which is really neat. But the other interesting thing is mentorship is one of those things that definitely supports that transition to practice being a little bit less rocky. But a couple of the papers that were pulled from the Lit Search indicated that training the mentees was also really important. And I think that's something we forget about, right? Is that mentees sometimes go into this mentor relationship thinking that it's all on the mentor to do the work. And they don't understand, just as you pointed out, Joe, that they are, for this relationship to really take hold and work for them to its fullest extent, you need to be reflective as a mentee. You need to be proactive as a mentee. You need to make time to really consider the things that your mentor is talking about. So there's a program, I just finished those 2 papers. I think it's OVC, but it's up in Canada, and they actually are integrating mentee training for through their 4-year curriculum for their students, so that when they get out, they understand their role as a mentee, and they're going to start following that. They're starting to integrate that, I think, into this year's cohort.
Yeah, and it's interesting because our postgraduate students have that conversation. Kerry Sakamoto does a lot about mentorship here. And for me, when I think the times that I get frustrated with students is when they're very passive and they want to be spoon-fed. Okay, so as a mentee, it's a similar mentality. If you want student-centered learning and you want to get the most out of that relationship, you've got to have your own goals, like help us help you.
Yeah.
So just similar principles.
Yeah, absolutely. So it'll be interesting to see doing
Yeah.
a quantitative study. I'm trying to push them to a little bit more qualitative, but we'll get there.
You'll get there, yeah. And I know that AVMA has just made a partnership with MentorVet. So there's definitely an initiative. It's only taken me about 10 years to really feel like there's progress being made, but that's an okay timeline, right?
That's pretty quick for academia in a lot of ways. So
Well, we're at our time, Joe. Thank you so much. This was a really great opportunity to chat and learn a little bit more about professional skills and all kinds of things.
Well, thank you so much for the invitation. It was a real privilege, to be honest.
Oh, thank you so much. It was, I love this. I love hearing stories and people's, we don't otherwise get to hear it. We don't do enough of this. So yeah, thanks for being here. It was great.
see, Bob, you're a qualitative researcher at heart. You love hearing stories. That's what it's all about.
Well, I write my own preamble, right? If I didn't know where it was coming from, and now I was like, oh, I was way off. That's okay. Your book chapters were better than what I'd come up with. Awesome. Well, yes, good to see everybody, and we'll catch everyone at the next Rive.
Thanks.
Thank you very much.